Hi, everyone. I'm MJ, the founder of Rethink Breast Cancer. And to officially open the event, I would like to acknowledge that Rethink Breast Cancer's office is situated on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. And finally, I'd also like to acknowledge that you are joining us today from many places near and far, and acknowledge the traditional owners and caretakers of those lands, wherever you're joining us from. And now I'm very excited to introduce Lindsay Davey, who is our speaker tonight, our expert, and she's a registered physiotherapist who specializes in cancer rehabilitation and lymphedema treatment. Lindsay's the owner and clinical director of Toronto Physiotherapy, and she's a very well-known and loved speaker and an educator on topics of lymphedema and cancer recovery. She's been an awesome resource for women in our community, doing a lot of writing for us, lots of articles on our blog, topics like courting and strengthening exercises post-breast cancer surgery. And so we are so excited to be discussing this really important, sometimes neglected topic, and just wanted to say thank you for being here to everyone and welcome Lindsay Davey.
Thank you so much, MJ and Shauna. I'm so excited to share more and as much as we can on this topic and related topics, much of which don't get a lot of airtime with sometimes with the primary care providers. So I'm here to be a resource, and I'm thrilled. So am I to share? Are we to go?
You're ready, you're gonna share.
All right, sharing. Sharing is caring, as they say. Sharing is caring. Okay, now I have just lit up my slides. I'm sure someone will buzz me in if they're not showing. And off we go. So I'm really hoping that you can leave tonight feeling very informed and very empowered. And importantly, if you have any questions that don't get addressed here, please feel free to email me. I'll list my email at the end, or you can find me easily. But don't leave any gaps in your knowledge. We're here to help, and it's important. It's important that you have all your questions answered. So I'll do my very best. So tonight's talk is basically a snapshot guide to managing ongoing survivorship issues, ongoing symptoms, and to leave you with lots of knowledge about what can be done to help them if you're experiencing any of these things. Let's dive in. We're going to cover topics surrounding lymphedema, who's at risk, how is it treated, reducing risk of infection, the all-important topic of exercise, scar tissue and radiation tissue effects, lots of questions usually surrounding that particular topic after acute treatment. Reconstruction considerations, many of our members and attendees may be considering or in the throes of reconstruction. I've added this in just one slide at the end, common vaginal and pelvic symptoms, given menopausal symptoms may be a factor for estrogen positive women with breast cancer treatment, and anything else you'd like to ask about. All right, lymphedema up front. What is lymphedema? Just briefly, it's the accumulation of lymphatic fluid, which we're normally producing all the time in every tissue in our body, but it's accumulation when it doesn't drain properly. And in a breast cancer scenario, the reasons why women are at risk of lymphedema is because either they've had some nodes removed, regardless of how many, that may increase your risk slightly, but either nodes are removed or the remaining lymph nodes or the lymphatic vessels are exposed to radiation. So those are the reasons why breast cancer is such a cancer type that lends itself to lymphedema. It can take weeks, months, or even years to develop. More often than not, it's in the earliest weeks and months following the end of radiation or after surgery. Who gets lymphedema? This is a frustrating one for many because no one seems to be able to nail down a particular number. If you look across the many studies that have looked at this, there's anywhere between 6 and 30% reported of breast cancer patients. So what does that mean? The reason is threefold. I think of it threefold. One, it's rare that the study group has had the same identical surgical parameters, right? Everyone has different nodes taken, slightly different complications that may have arisen, and so on. 2, what they define lymphedema as is a big variation. It used to be that they were looking for a 2 centimeter circumferential difference in the arm to define it as lymphedema. And frankly, that's evolved a lot over the years. And 3, it depends on how long the studies would look and follow up with their patients to determine whether or not lymphedema had developed. So that's why it's really hard to nail down on what is the percentage risk of lymphedema. We know several risk factors. More extensive surgery, number 1. The number of nodes removed. Of course, if you've had a full dissection, you're at more risk of lymphedema than if you've had a sentinel node biopsy. If you've had extra radiation to the armpit itself or above the collarbone, to nodes that live up higher, closer to the neck. Some evidence that tumor positive nodes can lend itself to higher risk of lymphedema. Certainly post-op complications. Advanced Webb syndrome. So there's a condition called cording, which we can talk about. Axillary Webb syndrome is quite extensive cording. I don't see that too often in my practice, but that would be on the list factors for lymphedema risk. Increased body mass. So more than 50% of women who go through breast cancer treatment gain weight during that treatment experience. So unfortunately, because of where women hold our fat tissue, typically over here, it's right in the same compartment that the lymphatic vessels course. So if you've gained weight or if you're heavier weighted, you are at increased risk of lymphedema for that reason. And finally, which is what explains when the numbers don't seem to make sense, is there is evidence to show that there is a genetic predisposition to lymphedema like every other biological condition. So that's why sometimes someone with a full node dissection from their armpit does not get lymphedema. We see those patients all the time. And why patients with a couple of nodes taken, sentinel node biopsy and so on, can develop lymphedema, okay? Because there's certain hereditary factors and genetic factors that are what they are. And until we're compromised lymphatically, we might know that we have some mutations for lymphatic flow. Okay, detecting lymphedema. So it can be an increase in arm or breast size. It can also be detected as an increased firmness or density, okay? That the quality of the tissue feels different. Certainly the arm, hand can be involved in breast conserving surgeries. The breast for sure can become lymphedematous, and the trunk, anywhere on the trunk in this region here that was irradiated. You may detect it as sort of increased creasing from your bra, rings or a watch that feels tight, that kind of thing. It can be triggered by a number of different things, and often we cannot weave the story. We don't really know what some patients, what tipped the balance for them. Yes, warmer temperatures. Yes, vigorous use of the arm, perhaps in an unusual or not typical way for your body. Air travel for some. Anything where you might swell anyway. So heat, air travel if you swell on flights, that kind of thing. But as I say, it's often that we can't tell for sure what it was, and it was going to come if it was coming anyway. Someone reported as feeling as a heaviness or fullness or an ache type feeling. I've had patients say it feels like a little bit of a tingling even. It can really cover the gambit of symptoms. Can lymphedema be improved and managed? 100%. And more, I really want women to understand that lymphedema is far more managed than it used to be. I know that some studies have shown, I remember when I first started out, women fear the occurrence of lymphedema more than the fear of their cancer recurring in a few studies. So I know it's a real fear for many women, and I'm here to tell you that it really doesn't have to be a major player, and you can stay ahead of the curve a lot of the time. How is it treated? So there's a classic sort of, the International Society of Lymphology has named this combined decongestive therapy. So CDT is the credential that you will seek out if you're looking for expertise in this area. It can be a massage therapist, it can be a physiotherapist, it can be a nurse. Someone with a CDT accreditation is who knows about this condition. And there's 4 pillars to how it's treated: lymphatic drainage massage, some form of compression, wrapping, or a sleeve, or taping we're using now more and more, infection prevention, and exercise. Okay, so briefly going to touch on each one. Lymphatic drainage massage. The idea is instead of the arm and breast relying on that armpit to drain normally, and we're making lymphatic fluid all the time in all of our tissues, and each of our tissues drains to a certain area where the lymph nodes act like as a vacuum. The point of the massage is to redirect your body regions to use other drains instead of the axilla, instead of the armpit that was affected by your treatment. It's not the same as a typical massage. You absolutely can go and get a typical massage if you want, and I encourage you all to do so. But if you're looking to treat lymphedema, it's a different style of massage entirely, and this is the credential that you'd need to seek someone out that has that CDT. There's a specific pressure, certain types of strokes, and a certain series of events that enables that fluid to flow in the new direction and without in the proper way. They're delicate little vessels, so if it's too much pressure, it will preclude flow, and if it's too light, it won't be effective enough. So it's learning that. Self-massage is key. So women can really take charge of this. Sometimes partners get involved, but given that you're trying to train your body to do something somewhat novel, we always encourage people to learn a little bit of self-massage if they're concerned, even as a preemptive measure, so that if and when you were to see some swelling at any point down the road, you've got some tools at your disposal. Pillar number 2 for treatment of lymphedema, compression garments. So the whole point is to prevent that backflow, that pooling of fluid in the tissues. There are wrapping, sort of like tensor bandage style wrappings that we sometimes use. More rarely, more commonly, it's the pull-on sleeves that you've seen and heard of. Garments can be custom fit if you need that, or many women deal very well with an off-the-shelf version. There is a provincial program of funding, a subsidy of 75%, and there's a few paperwork loopholes to get through in the beginning, but once you're in there, your garments can be covered at 75% for life, many garments per year. So that is a wonderful program. And each woman, importantly, learns how little or how much they need to wear their garments or when. I really empower my patients to play a little. You know, if they get through boot camp, we call it, and they've learned their self-massage, and if they've had some volume and they've got better control of it, and they know what triggers they have and so on for it getting a bit fuller, they use their compression as a tool in their toolbox. I would say less and less do women have to wear compression garments for every waking hour, which is what it used to be. So that's great news. Number 3 for treating lymphedema or managing it, infection prevention. So the lymphatic system is a fluid balance, fluid exchange system. The second thing the lymphatic system does is it surveys for opportunistic bugs and viruses and things that might come into that area and cause a local infection. So if you have a compromised vacuum and a compromised surveillance system, you can be at higher risk of infection in that section of you, okay? So your trunk, breast, around your back, and that arm and hand. The infection is called cellulitis, that's most common. And the only drag of it is it requires antibiotics to treat, because your body, if it shows itself, you weren't able to sort of combat it at the outset, and antibiotics are needed. So whenever the skin is broken, and I've listed many reasons why you might have a scratch or a break in the skin barrier, we just recommend that you use polysporin or some antibiotic style cream, and that mitigates 99% of what might take advantage of that break in the skin. Okay, so that's the gist of it. And people ask if they've got compromised veins on their chemo arm over the course of their chemo, and veins are hard to get, but blood work is still happening over their lifetime, of course, and through ongoing treatment. If they can have blood draws on their affected side, if necessary, if the veins are better, or if they need to get an IV infusion. Really, if you're watching for signs of infection at the site of entry of that needle, and you use polysporin and take some with you or mention to the nurse, you really shouldn't be at higher risk of getting cellulitis, and you could, in theory, use that arm. Some women have cancer on both sides, and so they have lymphatic compromise on both sides. So of course they need to use that arm. And I would say I've very rarely seen someone get cellulitis from a hospital-based procedure. So while we encourage people not to use that arm, you can if you're mindful of the risk of infection, and polysporin is the gist of it. Exercise. So this is the last pillar for the lymphedema conversation, though I add this slide in because I'm sure you're all aware, but exercise is so critical and so meaningful for so many reasons after cancer diagnosis and cancer treatment. I won't go through them all, but just suffice it to say, recurrence risk reduction for sure, lymphedema management for sure, but all these other symptoms you may be experiencing, really exercise. There's this much literature, volumes and volumes of literature supporting exercise. The best medicine, I call it. So aerobic exercise, I've asterisked the symptom fatigue here. Treatment-related fatigue, we actually call it TRF. It's a real thing. It's not solved by naps and good sleeps, and some women really have trouble getting their energy back after breast cancer treatment. So they've done a lot of research on this. In an aerobic exercise program, walking, challenging yourself, getting your heart rate up a little bit, and I'll give the prescription of what the generic suggestion is, really is the best thing to treat treatment-related fatigue. Counterintuitive, because if you're really feeling tired, the last thing you want to do is go out and challenge your body for 20 minutes on a fast walk. But it is absolutely the thing that can normalize your red blood cell count and improve oxygen circulation and really deal with the fatigue symptom, if that's anyone's experience. All kinds of other reasons why we encourage a walking program at the very least. We published a few years ago on just quality of life scores in breast cancer patients who exercised, obviously very much higher in those that did. And the generic guideline, the studies have shown, does not differ from the guideline for patients without a cancer diagnosis and non-survivors. So 20 to 30 minutes, 5 days a week at 60, 85 of what would feel like your max effort or target or in a target heart rate is well tolerated, and you can glean the same benefits. So that's the general rule of thumb, and you can work toward that if that's challenging at first. Now, exercise for lymphedema. It used to be, don't lift anything more than 5 or 10 pounds, sort of for life. Like that was the overriding rule of thumb. And certainly protect the arm and all this sort of thing. If you've had lymph nodes removed, certainly we've had a huge paradigm shift, and we know better now. And we know that, as evidenced by the dragon voters and women who exercise after breast cancer, it absolutely is supported. And for lymphedema, patients really do much, much better when they exercise. The contracting muscles in your arm promote lymphatic flow, particularly if you're wearing compression, but not all women need to. Weight training can decrease the risk of lymphedema, studies have shown, and no increased risk of new onset cases or worsening of symptoms with a progressive weight training program. Yoga, we get asked a lot about yoga. We've been hearing for years, of course, that yoga really helped people in a positive way with their lymphedema. And finally, about 2 studies came out a couple of years ago that prescribed a bit of a series of yoga movements that, and they did volume measurements, and over the course of the study, the women were having volume reduction in their arm from following a yoga practice that was tailored to that reason. Then there's lots of reasons why that is, and it's fascinating and wonderful. So the caution we do talk about is hot yoga, and some of our breast cancer patients do very well with hot yoga, and they love it, and that's important to return to if possibly they can. It's just because of the environment. It's warm. We swell a bit in warm environments. You'd want to make sure that your arm can handle that influx of fluid and drain it back out accordingly. So that's the little note on hot yoga. Exercise principles: if you have lymphedema or are at risk of, a compression sleeve may be recommended to wear during exercise. Usually women start out wearing one a little bit if they've got swelling, and see if over time exercise doesn't end up being a trigger for them. And in fact, they might find they don't need it at all. It's possible. Post-exercise self-massage to promote lymphatic flow. So exercise brings fluid into the arm, brings blood flow into those muscle groups. And if necessary, a little post-exercise massage can really help reset the balance in that arm. Keeping cool as best you can. We recommend a combination of aerobic and weight training. Lots of studies have shown that's a good combination, and there's some rehab programs in the city that use that model and do very well. Progressing exercises for the arm and chest a bit more slowly. So if you've had radiation, your pectoral muscle has also been exposed to radiation. And that's not thought about a lot, but you've got an irradiated muscle that then if you're asking to do a lot of planks and push-ups and chest press and bench press and so on, we just caution people to dial up their chest specific exercises slightly slower than they might have or that they did before treatment to make sure that that pec is, that the arm can handle the fluid influx and that the pectoral muscle can contract and relax as it needs to avoid injury. And evidence supports lifting heavy weights if you were a heavyweight training person or if that's a new goal for you. The studies support that totally in a breast cancer and lymphedema perspective. So if that's your goal, you can get there. Scar tissue and radiation effects. Okay, moving away from lymphedema. This is experienced as tightness and pain or pain across the chest, breast, armpit, shoulder, neck, back. I'm seeing more patients coming in with really neck and shoulder symptoms lately, ascribed, which is attributable to the radiation, says the radiation oncologist, and I totally agree. Ropiness at the scars themselves, the node removal scar, the drain sites can be a source of pain. Cording. Briefly, what cording is, cording feels like pieces of floss almost, sometimes a little bit bigger, and they typically extend from the armpit into the arm. Some people feel it all the way down to the hand. Some people, they're very short. They can be across the chest. They can be on the trunk beneath the mastectomy line or beneath your breast. And what it is it's a lymphatic vessel that lost its node or nodes. And in that process, that scar at the top renders that vessel adherent and sticky to its environment along its path. So there is a way to release cords. Patients have particular homework movements they can do. We sometimes get lucky and it's entirely very satisfying when it works, and it often does. And range of motion can quite quickly be improved if cording is the reason for a shoulder stiffness feature. So that's what cording is. A lot of the docs will say, just give it time, give it time. In the meantime, however, it's not my favorite thing as a lymphedema therapist because it is on our risk factor for lymphedema, and moreover, it limits range of motion, is uncomfortable often. So I'm all about addressing cording if you have cording. Scar tissue and radiation effects can render a shoulder quite stiff. We see some frozen shoulders. We see some rotator cuff tendonitis, limited range of motion for sure. And in the breast, we see this a lot. The breast can swell because of radiation, sure, because of surgery, sure, if you had a lumpectomy. And over time, that swelling can become harder. There's no muscle pump in the breast. So unlike the arm, hardening of breast tissue or hardening at the scars can occur over time just from stagnant fluid sitting in there. The vacuum's not working great. And what are we left with? And it can be quite uncomfortable, obviously. If you've had reconstruction, you have an expander or an implant in your chest, radiation can render that more sticky. There's a term called contracture, which is the capsule around the implant getting quite sticky and rigid. And this list of items can absolutely be improved. This is a big factor for function, for pain, and should not be ignored. I treat this more than I treat lymphedema these days, it seems. And the great thing is once you release the radiation tissue and release the cord or soften the hard breast, there's no mechanism by which that returns. If it's from radiation and you soften that radiation tissue, it doesn't come back, which is wonderful. So they are treatable. Next slide. Stretches alone typically aren't sufficient. So everyone's done their wall walking after surgery and the doorway stretch, and that's fantastic and really important in those early days. If you're having radiation or scar or fascial restriction, really the stretches aren't enough to untether that stickiness. It requires some work. I'm all for teaching patients how to do it. It's not difficult. It can be uncomfortable. Never usually as uncomfortable as it goes along because there's less and less that's sticky. And the stretches thereafter really have more role to play. I call it like a Velcro type effect, and that's what I feel, or saran wrap. The manual softening and release of these tissues or hardened swelling for sure is highly effective to decrease pain, as I said, improve the tissue quality, and therefore lymphatic flow, particularly if you had breast conserving surgery. So if you're having swelling, or if the breast from the radiation effects is harder, and it's painful and it's stagnant, you don't want a lymphedema, a breast lymphedema scenario taking on. Improving the range of motion for sure. Sometimes in 1 or 2 sessions even, it's quite exciting to work on with people because it really can make a big difference in a hurry. And you need that for your shoulder. Every woman, but particularly young women, need to have a functioning, great ball and socket joint for all the rest of their many years. And so it's important to get these, I would argue, these tissues back to feeling good. Reconstruction support. So I've just put the laundry list here of things that we see in our reconstruction patients, regardless if it's an expander, an implant, delayed reconstruction, immediate reconstruction, the lat flap, the Diet transfer flat, or the fat grafting, which is we're seeing more and more where liposuction occurs, or fat is taken from one area and put into the breast region to improve the landscape, or areas that are a bit sunken. All of that can cause their own challenges. And if there's swelling, pain, stickiness of the implant, stickiness from the latissimus scar across the back, any of those things, core strengthening after a Diet flap for sure. Women often come in with postural effects after reconstruction, regardless almost of what type. Because, you know, while you're healing and you're in protect mode and everything else, there can be quite a forward tendency, and restoring that sometimes takes a bit of help, but well worth working on. And of course we monitor for lymphedema. Sometimes I get this question, is reconstruction a risk factor for lymphedema? And I don't see that. I don't see my patients with some lymphedema worsen with a reconstruction procedure. And I don't see that as the trigger for new onset lymphedema in my patients, I can say. Just briefly, we're almost finished here, vaginal and pelvic symptoms. So these are common, of course, whether chemotherapy may have rendered you having menopausal temporary or more permanent symptoms. If your breast cancer was an estrogen positive type and you are on tamoxifen or Arimidex or letrozole or what have you, vaginal dryness and pain with intercourse and all those symptoms, you may not be in the hands of a gynecologist or a gynae surge if no further intervention is being investigated there, in which case I highly encourage you to speak to any of your team members or a pelvic health physiotherapist. Like getting a trigger point in our tight muscles here or in our pec muscles, you know, through this experience, you can certainly get tightness and tension that's perpetuated vaginally with dryness and menopausal type symptoms. So my colleague, I think, is going to be speaking to this, and more and more we get questions about this, and it's meaningful to bring up because it's not touched about a lot, I think it's fair to say. Pelvic health physiotherapy, I won't go into any detail, but there's many tools they use to render that really feeling a lot better and in more control of that aspect in our breast cancer patients' lives, particularly those who would have been or are premenopausal, other than their treatment experience. So that is where I was going to leave it. I think I've kept to my 20. And yeah, go ahead, MJ. Sorry.
Sorry, I lost my voice. You were doing all the talking, yet I sat here quietly losing my voice. Thank you. That was wonderful. Really covered a lot. Do you want to stop your screen share for a minute?
Sure. Yes, of course. Yes.
And there's my questions. So we did field some questions, and you covered a lot of them. We did receive a lot of questions, and I have a feeling that everyone who's joined us right now is going to have a lot of questions. So
sure.
I was just scanning them earlier this afternoon, and I saw kind of groupings, a lot of how long after questions came in. Yeah. So questions like, well, how long after my surgery should I be worried about lymphedema, like the lymphedema risk? How long after surgery should I be doing my mobility exercises? And I think if I'm taking away what you we're talking about, that it's kind of a lifestyle, like it's ongoing, but maybe I'll just let you answer those two.
Yeah, sure. I would say on lymphedema timing of risk, I tell my patients you know, every day that goes by, every week that goes by, every month that goes by after treatment has ended, it's less and less and less and less likely to appear for the first time. That is true. It's exceedingly rare, I would say, that I see someone even a couple of years after. Now, everyone on this meeting tonight, I'm sure, is earlier days than that. So I would say I always take it as a big win when the first summer passes by, because there's hot temperatures, humidity, all that. So here we are approaching September. That's a good thing in my world. I like the cooler temperatures coming. Shopping at Christmas time, I will say this, always brings a few people in, or speed walkers or joggers that jog through the winter, because we wear winter coats to the mall. People bundle up for their outdoor exercise in the winter. They get quite hot, and anything that makes women warmer is just to be on your radar for a while in terms of, does my hand look different when I get home? Does it feel kind of heavier at all? And that's why I love people sort of knowing a little bit about how to do some self-massage, and even preemptively perhaps doing that for the first few months, I guess, after vigorous exercise and vigorous use of the arm. Nothing could make me happier than that. It may be more than some women need to do, actually, and they might never be bound to get lymphedema. It's the most frustrating gray answer, I know. For the most part, I would say it's on the order of weeks and months, not months and years. So if you know that your lymph node number removal is low, if you're a sentinel node biopsy person and you didn't gain a lot of weight during treatment, and you're fairly active and that's all gone very well so far, and your range of motion's back, and you didn't have complications after surgery, things would be looking quite good as the weeks go by and you haven't seen any swelling. It's not a black and white answer, but that's the best trend that I can say I see. The other question was?
It was about the mobility exercises. So specifically the post-surgery, you transition from the initial mobility exercises. If you want to keep that range of motion, do you move into ongoing exercise?
I would say definitely the lying on the beach stretch and the wall walking and the pendulums and all the really early post-operative stuff is essential for a couple of weeks. And then you'd want to make sure that you move into the phase where you feel quite good. You feel that you really can have quite a bit of freedom of motion in that affected shoulder. If there's ongoing pinch at the top of the shoulder with like hand behind back or full elevation, or you feel that there's just a tightness, a Velcro, a saran wrap, a whatever across the armpit and chest, the wall walking and just the stretches in the doorway don't tend to be enough for that. And I would say learning even one time or going after it yourself and massaging, and it feels dicey to do it first and uncomfortable maybe for many, and I understand that totally, but softening that a bit truly, and then doing more stretches is really phase next, I would say. Once your shoulder range of motion is back and you feel you can raise your arms and feel quite free, then I would say you'd move into the phase where you're doing exercise that fills your cup and that you feel good about, and you can start to work on strengthening and aerobics exercise and all that. But the perioperative range of motion stuff is as soon as your sutures are healed and a couple weeks after your last radiation dose has passed, you should pursue getting full range back. And if you feel limited by tightness, to try to soften those tissues first, then do your stretches. And if that isn't enough, then I might suggest you see someone to get it back. And you don't need to wait. That's the other question. Some people are nervous to get in there too soon. If your suture line is healed and the radiation effects are doing, it's worth it to get your range back. I would say sooner than later for the health of your shoulders.
Okay. And there's never a situation where, okay, you did the initial range of motion, you moved into the second phase, and then something happened in your life, new job, for whatever reason you weren't exercising. Could you regress and lose it, or you got to just get over that initial range of motion situation?
Once you get over the initial range of motion and you get 80, 90, 100% of your shoulder range of motion back, I haven't seen regression when people fall off, and that's okay. Like life takes over, and the whole point is to get back to normal in my mind. So homework forever is overrated. I would never, I don't believe in that.
Okay.
But I believe in trying to get to it, to get to where you feel pretty full and free, and then you carry on. And no, I would say you wouldn't need to continue to do range of motion exercises.
Okay. And how long should someone be worried about having blood pressure or having their blood drawn from the arm that's been their surgery side? That was a question.
I would say those, those early few weeks, like really short timeline on just not wanting to provoke anything in the arm too soon when it's just lost part of its vacuum or just finished its radiation, which doesn't help lymphedema risk. But beyond that, and yes, if you can get a blood pressure cuff on your unaffected side, the golden rule of thumb would be, why not then use the unaffected side? Blood draws are what get tricky, because chemotherapy, some people's chemo regimens really tax the veins on the opposing side. And so I would say, there's no timeline really, but I would say as soon as, if you're on Herceptin or you're on something longer term, and you need to have blood taken or an infusion, we still would say if you have a great vein on the other side, sure. Why provoke any chance of skin break? Similar to, I wouldn't, be a cuticle muncher, and I wouldn't scratch a bug bite vigorously on that side if I could possibly not. I wouldn't. So I guess I wouldn't if you wouldn't have to, sort of for long term. But as I say, with lymphedema, and I would say cellulitis is the same, every week that goes by, it's less and less likely. That's what we see. It just becomes less and less likely to occur. It's not a black and white, but it's fairly compelling that if you can get through the fear, and then the question, I know everyone wants to know, yeah, but how long? I know. It's tough. It really depends on people's node numbers and how their course went as to how much they need to be vigilant about that. I would always say be as conservative as you can, but if you don't have it, don't have venous trauma on the other side either, for that matter, take polysporin with you, and and that usually does very well to protect one.
Yeah. A couple of radiation questions came in before the talk, and one was, in terms of the tightness, would it be helpful to see a physiotherapist before radiation treatment starts?
Oh, great question. I don't think so. As we are. If you have full range, now the only thing I'll say there is, if you think that there's any reason that you'll have trouble, let's say from surgery, how you've healed from surgery, getting to that 90-90 position for all those radiation treatments coming, the 16 days you've got to go and have your arm up there, that would be worth making sure you can try to maybe optimize your mechanics at your shoulder orthopedically, so that you're not going to run into you can get tendonitis or a bit of a rotator cuff challenge if getting to that position is challenging. That might make me want to see a physiotherapist once to sort out some exercises and strengthen that rotator cuff so that it can handle that. If you don't have any range of motion limitations ahead of radiation, there's no preemptive strike on or if you're woefully posturally tight, I wouldn't think you'd need to see a physiotherapist. I would start lying open and get some range, like just start stretching the doorway stretch stuff. You could get some length in your pecs before radiation starts from that perspective. But no, you wouldn't need to be released probably by a physiotherapist before radiation.
I think we all sat up a bit straighter.
I know.
About that.
Totally.
A question that came in is, what's a safe way to stretch radiated skin while in expanders?
Oh, while in expanders. So actually the expanders are implants or breast still there, or mastectomy type scenarios, all four. But specific to expanders, like I don't change my advice on how to stretch pecs based on those things. Some women now are having their pectoral muscle left on their chest wall and the implants going above. That's sort of a nouveau reconstruction option. More classically, the pectoral muscle, which is probably what this woman is wondering about, is lifted and the expander goes underneath it. So stretching your pectoral muscle with the knowledge that it was sort of stretched a bit is a valid question. But from the plastic surgeons I've spoken to over the years, it is way more robustly, solidly in there. If you've had alloderm, which is sometimes used to create more of a pocket under the pectoral muscle, the suture line between the pec and the alloderm is very solid. So there is no reason to be conservative in your stretch technique. The only thing I say about pecs is sometimes people just do the 90-degree position, and there's at 105 and 115 and 135, the pectoral muscle is a bit of a fan. So I would say doing 30 seconds, 60 seconds in one position, and then moving to the next and to the next and to the next. Whether you're on the ground, lying on a foam roller, or just on the ground, or in a doorway, any of those options are fine, expander or not, frankly. But I would just use different positions of the arm to get more of the pec muscle lengthened.
Okay.
Yeah, if you're at all concerned, you can always sort of hold the expander down, I guess, while you stretch. If that feels more secure, that's fine, but it's quite unrisky, I would say.
Okay, I'm going to start going to some of the questions from those here tonight, but just squeezing in two more that came in advance. Sort of the idea of almost like lifestyle stuff. So if you work at a computer, does repetitive small movements like using a mouse, does that increase lymphedema risk? Or sleeping position, maybe you have your hand behind your head? Are those kinds of things that, maybe can cause cording, or any kind of concerns just about our general day-to-day
Great
life?
question. I would say the only concern about lots of mouse use or laptop use is more the shoulder, the classic shoulder issues that can come about that, or tennis elbow or wrist stuff. Lymphedema, no. Just lymphedema doesn't care how you sleep, and it doesn't care your workstation position, truly. Of course, we want people to pump during their day if they possibly can. Just as the natural arm gets pumped, fluid gets sent back to home base. So long periods of no motion would possibly be not ideal. Certainly if you have lymphedema, we want you moving more. If you're wondering at a preventative measure, being good posture is good for all the orthopedic reasons, but I wouldn't put that on your concern list for lymphedema. If you have lymphedema and you're too bent up in a poor position, yeah, we don't want creases forming unnecessarily that would lock fluid from flowing easily. But my patients always ask about sleeping position. They said, oh, it's my right side. I always have slept my whole life on my right side. Is that going to be a factor? And the factor of not sleeping comfortably is far worse for lymphedema and tension in the shoulder and neck and everything else. No one in the lymphedema community, well, I don't suggest you alter your sleeping position. So that's not a risk factor.
Okay. Looking at a couple of questions here. So one is, can lymphedema be localized in one area, like just the armpit? Like it's not all through your arm?
Yeah, so absolutely it can. In the armpit would be possible. More often we see it like just sort of on the upper trunk, and some women aren't sure, is it my upper arm or is it my trunk? Because it feels strange when I contact it and I'm still kind of numb and all that. It can certainly be local. It can be just a pocket under here. It can be just the breast. It can be feels like it's just in the upper arm. I would say it would be rare to have it in the hand and not have it in the rest of the arm, for example. But it can sort of appear, it can appear in little regions. You don't have to have the whole thing involved. That's true to say.
Okay. And I know in your presentation, you talked a lot about how to manage lymphedema, but is it something that you're always managing for the rest of your life? Like, does it ever completely go away? Or if you have it, do you have it for life? And you always have to be aware.
Yeah, that's a great question. If you Google lymphedema, the Wikipedia answer would be, it is a chronic progressive condition by definition. However, which means always there to some extent, and if left to its own devices, going to get worse. I really find that a wild over generalization. And most of my patients, if they have new onset swelling and they kind of up their interest in self-massage, maybe some compression wearing, altering their exercise program a bit, if that is a factor there, all those things, truly managing lymphedema is very, very possible. What does managing mean? For some women, it means, wearing a sleeve on flights and on lawn cutting days in July only. For some women, it's I wear a sleeve for exercise, and that's all. For some women, it's after tennis, I have to do self-massage, and that's all. So, and some women, it's, I don't have to do anything, but I'm just watching that after I go in a hot tub or hot yoga. Am I feeling, do I need 5 minutes? Do I have to just help my arm drain for 5 minutes? I have women with full dissections of arms that have had lymphedema that over time seem to not, or I call them my 5% club. On measurement, they might have a slightly bigger hand, forearm, arm, like barely, that you would never tell, but that we get our, you know, and we're really nitpicking about it, and we can tell, okay, it's slightly bigger, but it doesn't do anything. It's not, it doesn't seem to be able to be provoked. And they have their own list of things that they know might trigger and that they might have to do, but overall, it isn't something to fear as taking over the way that it maybe 30 years ago when they did very aggressive full dissections, radical mastectomies. It's just not, and more radiation and more exposure. It's just not like that anymore. So I would say it's far the exception to the rule that women have to feel like they're grappling with it forever.
Okay. I'm going to ask one more question from the Q&A, and then we'll see if anyone wants to raise their hand. So we have someone who found it difficult to find a physiotherapist in their area that specializes in breast cancer patients. And is Zoom or these remote sessions that we're all getting used to these days, would that work for someone who's just not able to access someone right where they live?
Yeah, it's a good
expertise.
It's a good question. I would say, so when we had to close due to COVID, and there were women still having their acute surgeries, and radiation was ongoing there for some that had to go through it during that time period. So I can speak from experience, having done quite a few Zoom calls. The initial information like this, now they have that, I hope, and I hope it's been useful, but the how to massage and the how to, like having a look at someone's biomechanics and where is it tight and what does it feel like, and show me, like, you know, I have women saying I'm ready for prime time and on go, and it's fine. And really it was less cumbersome than I thought. I found it was positively received in terms of, because you can usually tell like how vigorous is someone squeezing and releasing, and no, don't pinch like that. It's a little more open-handed, like this kind of thing. So I would say if they really can't access someone locally, it wouldn't be, I think it would be worth their time to connect with someone on my team or otherwise to get some specific to them instructions.
Okay.
How to.
Cool. Thank you. Okay, so Shauna, I can't see if anyone's raising their hands. I've still got lots of questions that I can ask from stuff that came in ahead of time.
Yeah, so far, everybody's choosing the Q&A option. Yeah.
It's so efficient. Okay, great. I will take
women for you. That's women for you.
I think we scared them by telling them if they hadn't updated, they were going to pop up on the screen if they had an old version. Anyways, let's see. We had a couple of questions regarding, someone asked about dry brushing, and I don't think you mentioned that. Can that help reduce someone's risk of lymphedema?
Dry brushing is, it was sort of a hot topic that came up. It was interesting. I only started hearing about it maybe a few years ago, and I get that question once in a while in my patients too. Anything really, basically, if something is done in a sequence of events that would be instructed as to how to self-massage for lymphedema in a breast cancer scenario. So we start at the neck. There's a video on my website, and there's lots out there online of how to massage the neck to wake up all the lymph nodes that live here, to turn on that master vacuum and so on before you move on to the arm or the breast or the trunk. If massage itself feels cumbersome, or someone's having trouble getting the knack of it and they would rather use a dry brush, if it's in the series of events that would be optimal for drainage and it works for them, I'm totally into it. There's something particular in our training that having the skin stretch a little bit with each stroke is thought to promote the valves that are within each lymphatic vessel sort of push along that fluid. So I don't know that with dry brushing, you get that same optimal flow milking action. So that's the only thing I would say is if someone was going to follow along in a DIY lymphedema massage routine and they were more comfortable, sometimes even for reaching, having an implement helps women, then I'm all for it. If they found that didn't work well, I would encourage them not to cast aside the notion of self-massage and to try, or to get a partner or someone that could do it with them using hands, because it may be that just the dry brushing wasn't quite getting it. Does that make sense?
Thank you. A couple of questions related to pain came in. So one is, what can I do about painful scar tissue a year and a half after a lumpectomy?
You would hate me or be, it's not terrible, but the thing you don't want to do is go right after that scar. And in a lumpectomy scenario, that's the worst because you still have a breast intact. There's tons of nerve endings, many of which are entrapped in that scar line. And the surgeons always say, do little circles on the scar, and that's fine. But often the scar is like an iceberg. I talk about it like an iceberg. So the line that you can see on the breast surface is here, but really the scar can be quite a bit broader underneath. And so there's a lot of nerve endings that can be quite fiery and painful. Some women can't rest on that side. Some women can't wear a bra months after. Some women, their kids come at them for a hug and it's very sensitive. My best advice is to put some cream, your favorite cream, on your hand. If it has a bit of an analgesic in it, great. I use a massage type cream, doesn't matter. And to soften and roll it and twist it and go after it. And it's the last thing you want to do. But if you can release those fibers that are sticky and stuck in there for that period of time, it's not the most comfortable to do. Once you break it, it doesn't return. So that's the most satisfying thing I do on people is try to be as really charming while I'm doing it. And it can be really meaningful very quickly, actually. So if a year and a half has passed, it is not too late. Women always ask that too. Like, if I missed my window? No, nonsense. Go after it if you can. If you've got a partner and they can get involved, that. Some women hanging forward and having the breast hanging a bit means you can get it more corners of it. Just to go after it and massage it, but like lying on your back, pressure downward in, circular massage won't do it probably. You need to kind of have it in your hand and working it if you can.
All right. Okay. Well, moving away from the breast a little bit to the elbow, someone asked about chronic joint pain from arimidex. So specifically elbow pain.
Arimidex that's the most common thing we hear is arthralgia. So joint pains, myalgias and arthralgias. So particularly what I find in my arimidex patients is if they had, whether known to them or unbeknownst to them, a joint, little bit of arthritis or a little bit of tendonitis or something already, arimidex in some patients seems to dial that up a lot. So I've had patients that have a little bit of neck arthritis and it goes fiery with arimidex, or this might be an elbow scenario. If it's truly a drug effect, I would treat it like someone like that might be able to see a physiotherapist, not with breast cancer expertise, and just deal with whatever might have been there smoldering in the background that arimidex has dialed up the volume on, like a tennis elbow or golfer's elbow, it's called, and get some TLC and some advice on classic just elbow condition treatment options. Speak to your medical oncologist. That's a tough one if it's really taking over. But given if it's an elbow, like if it's spinal pain or kind of an overriding body ache, definitely your medical oncologist should be aware in case they want to alter anything or give some advice. If it's local, my guess is there's something smoldering there already, or that's new onset. Who knows? If it's on the same side, and getting that treated orthopedically could actually really, yes, arimidex spurred it on, but it might be quite treatable.
Okay.
It's hard to say what you would do depending on what is going on at that elbow, but I would go after it.
Okay. Just looking over at some of the questions, there's another, I'd say, kind of lifestyle-y one. You talked a lot about trying to keep cool while exercising. Don't bundle up too much, even in the winter when you're exercising. What about a sauna? Someone asked if a sauna can increase lymphedema.
Yeah, saunas and hot tubs always come up. So hot, just briefly, because everyone usually asks the hot tub question too. Hot tubs, in general, anything where your body gets warm, all of our blood vessels dilate, right? And we can all get a little bit like rings can't come off, like full swelling. And that's just our body's way of cooling us down in a hot environment.
Yeah.
A hot tub, sometimes I say, well, if you have lymphedema, watch that it doesn't make it worse. For me, we don't want to make lymphedema worse really at any cost. So if it meant hot tubbing had to leave your radar a bit, or at least until you're more managed with it, then I would probably recommend that. If you had your arm out of a hot tub on a cool hot tub side, that might help. Though, as you can imagine, being in a hot tub, even if your arms are out, you can still get quite hot. And it's the body getting hot that would cause, your hands to swell and everything else. A sauna most definitely is your whole body getting warm. But I'm not a black and white. Some of my patients love their sauna and their hot tub experience. And I would never say black and white, you can't go in there. No. So
if it's a girls' weekend, some kind of spa,
I would say it's trying it in low, like maybe for a short period of time, and then maybe going into the cool pool to kind of body blitz yourself a little bit to mitigate that overwhelmingly hot feeling. And just when you come out, have a quick gauge, like have a look, make sure you're not seeing or feeling anything fuller. And if you are, know that you might want to help get that fluid back out again if you're not sure. But I have lots of patients that return to all those activities. Truly they do. So I would say if it's a plan and it's important to you, particularly if you own one or something, but even if it's a getaway thing, just be mindful of low dosing it and make sure that things seem to be feeling okay versus committing to a big chunk of time. Because, I'd be lying if I said historically in the past 15 years, yes, I have had the odd occasion of someone saying I was pretty good. And then I think that was the thing. And and then it's not to say it can't come back down to where it was. It's just, you'd have to know that you wouldn't want to regret it if it went awry, right? And everyone's risk tolerance is different. So that's all I just caution people. But in principle, I'm all for it if it isn't, if you're watching.
Yeah. So a lot of our conversation tonight, it's focused a little bit on the very sort of early days of diagnosis, first surgeries, things we can do. What about if you are metastatic, you're in ongoing treatment, maybe you have bone metastasis? Is that something where, exercise to prevent lymphedema or other things is not recommended? And kind of expanding on that, is there ever a situation where exercise is not recommended?
I would say in recent years, they've really, I'm thrilled, they've invested a lot of time and studies have focused a lot on women with metastatic disease and how we can support them. And I lecture on this actually to the new burgeoning physio students too. So in a nutshell, with the right certain limitations in place for someone with spinal metastases or long bone metastatic disease, you can still absolutely exercise, even weight train with certain caveats and rules of thumb to follow. You'd want to maybe have a program designed for you by someone that knows what they're doing. And if it's by Zoom, it's by Zoom, and I've done some calls like that. If it's visceral metastases, so you have a liver or a lung lesion or something of an organ nature, then so long as you have enough fat, you have enough energy and your blood numbers are in good shape, then aerobic and weight training is very much a really important thing to still be doing to keep all other systems going and being strong and healthy. But with bony metastases, it's exciting. The recommendation is to load bear and is to strength train and is certainly to walk and all those things. Being mindful of a few issues like twisting with load, longer levers, heavier load with momentum, those kinds of maneuvers would want to be avoided. But otherwise, there's lots of ways to strength train, and I've got lots of patients that do and it's absolutely critical to their feeling of wellness.
And I think that made me think of a point. It wasn't something anyone asked, but just that you should always check with your doctor when embarking on a new, or your healthcare team.
100%. There could be, you might know it ish where you have a metastatic lesion, but it seems stable and they're just watching and everything is great. But there may be a particular move in yoga or whatever it is that you just want to have in your mind. Oh, that's not for me. That one thing on this list of things I want to do, that one's not for me. And there's lots still to be able to do.
Thank you. I think we just have a couple more questions, two quite different ones. So one is, does antiperspirant or deodorant impact us? Meaning from the perspective of, does it add to accumulation of liquid by blocking sweat?
No, we haven't found. I know that's another buzz topic that people wonder about. I don't know. I can't cite any paper that is concrete on a lymphedema connection to use or disuse of antiperspirants or deodorants. So I would say not to my knowledge. I don't see that trend.
Okay, that's good to know.
Yeah.
I think during your presentation, you mentioned immediate reconstruction, but also delayed reconstruction. And someone's asked, can lymphedema occur years later after the surgery? So especially if someone's undergoing future reconstructions, maybe years after their initial surgery.
Thankfully, I mean, there's no black and white certainty, but I can tell you of all the delayed reconstruction women I've seen over the years, I have never seen that be the impetus of a new onset lymphedema case. I think 0 times. It's, because a reconstruction surgery often involves many hours and IV and fluid. The experience of having that kind of surgery is you have lots of IV bags being infused. So that fluid overload is sometimes people's concern, like, will my arm be able to handle that experience? But I find people do, and people with lymphedema that have reconstruction, we don't find it gets worse, truly. So often reconstruction, frankly, there's some scarring and some things that this plastic surgeon, when they're in there, debrides a bit and cleans up a bit. And sometimes that can really improve some range restrictions or something that was impeding flow, arguably. So I wouldn't concern about lymphedema in a delayed reconstruction scenario. There's no guarantees, but I don't see that trend.
Okay, thank you. So I think we can close pretty soon with just a couple broader questions came in, which might kind of leave us with some parting words of wisdom. You've given us so much very specific information, but what about sort of pre-surgery advice? So if someone were diagnosed and they haven't really started their treatment at all, no surgery yet, is there anything they could do before they get, have any work done that's going to help with that post-surgery recovery?
Yeah,
I would try to get as flexible as possible. Or
yeah, I would say if they know they have really it would come down for me, a pre-existing shoulder issue, or any reason that they don't have full and easy range of motion on that side. Surgery is one thing, but embarking particularly on radiation can certainly tease out old shoulder problems, it seems, which is just a drag to have to, and then, in my patient caseload, I'm seeing someone, lovely woman that's dealing with this, and then we're dealing with this. So if you had any lead time at all before surgery, you've got a couple of weeks and you're preparing, if you know that you have a little something going on, if you could get some advice, like just starting some easy strengthening, being mindful of posture ahead of surgery, that's one thing. The other thing is learning self-massage. There's so much going on usually in that time frame. I don't usually fuss about women doing self-massage before they even have any node compromise, because your system's running at full already. But knowing what resource you might pull up 10 days after surgery when your drains are out, you've got a little more, ability to take on a new project. Knowing, whether it's, again, any link, there's many links out there to videos where I have one of myself from a long time ago doing the neck strokes. Some women come in preemptive to their surgery to learn the gist of what to do. They want to know what's this thing about garment, like just so that there's less on their list that seems daunting. But really preemptively, I would say there's not a lot. If you knew you were going to have a full dissection of nodes taken, those might be the patients that might want to know a little bit about how to drain the arm in the event that within that first week after surgery, or, they start to feel full, because then mobilizing oneself while the drain's still in, trying to find a resource for how to do it then could be quite, it could just feel like a pile on. So if you knew that it was going to be fairly conservative and really there's no rush. I hate for women to feel like they were already behind before even begun. And I really would say to patients all the time, like, you haven't lost, this train hasn't pulled out, it's totally okay.
That pressure to be a good patient.
Yeah. Yeah, it's true. It's true. Just forgiving, like letting yourself take on things as they come is, patients tend to do quite well when they approach it that way. If you're anxious, you're feeling all the feelings and you want to have your resources together, then we do sometimes see patients preemptively, and for them, that works for them. And then they have their if then scenario. The one thing I'll say is after surgery, the pamphlet talks about finger, like wall walking, and the doorway stretch and some shoulder circles, and then it kind of ends. And so some women don't know, like, what do I, like, when is it safe? Am I gonna, and my rule of thumb is, for the first couple of weeks, you don't want your surgical site to splay. It's not going to do, the chance of infection is low and all those things, but you want usually a nice thin surgical line. But after a couple of weeks, 2-3 weeks, certainly by 4 weeks, really it's quite well knit together there, the wound site, in which case range of motion of the shoulder, you want to start to make sure you're getting on top of getting it back, I would say. And pre-radiation, the optimal would be to have quite full and free range from surgery before radiation. Okay. Because radiation does have this sticking effect. And if you're already going in sticky, that can be challenging. Okay. So that's the one preemptive strike I would say is between surgery and radiation.
Okay. And one final question. Thank you for that. One final question, again, kind of broad. What else can we do to keep our bodies strong? So whether it's, continuing with ongoing treatment, maybe in anticipation of another surgery down the road, what are your final words of wisdom?
I would say, find something. If you had an activity or a hobby or a type of exercise or whatever it is, assume that that's going to still be, a part of your life, and to get back to it as soon as you can, because that will return that feeling of normalcy. The sooner things in the rest of your day feel normal, I think those women do the best. I would say, not to fear. It's easy for us to say, of course, but not to worry. If something comes up, and if an infection happens, or if there's a hurdle in the road, it can be sorted. It can be sorted totally. You'll get your shoulder back, and you won't have limited range. And I've seen every which way the story can go, and in hindsight, it's always everyone's journey is different, but to not fear hiccups along the road. They may happen. Have someone on your team that you feel you can reach out to, and people can email me if they have any questions or anything, but just to know that there are resources out there to help, and not to feel in anticipation of what's to come. And that's easy for me to say, but.
Thank you. That's helpful, I think, for all of us to hear, for sure.
Yeah.
Well, I just want to give you a big heartfelt thanks for being here tonight. Thank you for coming here to chat with us. And we know you're super busy, especially now with probably so many Zooms. So for you to take the time on an evening and be here to answer all our questions is really appreciated.
It's my pleasure. I hope it was helpful.
Very helpful. And just also on that note, want to give a big heartfelt thank you to everyone who joined tonight and asked such great questions. And thank you once again for sending them in advance. That's always helpful. And again, just want to be thankful to those that are supporting our community and allowing these kinds of events to continue. And I hope everyone has a great night. And
Well, thank you. Thank you to everyone. Good luck, everybody. Don't be
Thank
shy.
you. All right. Bye.
Bye now. Thanks.